This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
My name is Kelly Rulison, and I am on the SCRC Methods Core. Today, my presentation is going to be about the Multiphase Optimization Strategy, or MOST framework, and we're going to focus specifically on how we can apply MOST to the suicide care pathway. There is a good chance that you have seen this figure already, which illustrates how the SCRC is combining the DDBT and MOST frameworks to design, optimize, and evaluate interventions. This top row lists the 3 phases of MOST, and the goal today is to provide you with an overview of what MOST entails and what is included in each of the 3 phases. More specifically, there are 4 key objectives for this presentation. I hope that by the end of the presentation today, you will be able to describe the key differences between the classical treatment package approach to intervention, design, and evaluation and the MOST approach. That you'll be able to identify the 3 phases of MOST and describe the goals and activities of each phase. That you'll be able to explain the key characteristics of a factorial experiment and how it can be used during the optimization phase in MOST. And that you'll be able to identify some potential challenges that can occur in the optimization phase and think about how you might address each one of them. MOST is an engineering-inspired framework that focuses on optimizing and evaluating multi-component interventions. We'll talk about what some of these terms mean within the MOST framework shortly, but for now, one thing to keep in mind is that MOST can be used as a framework when you're just getting started designing a brand new intervention or tool. It can also be used if you want to take an existing intervention apart to make it more efficient or more effective. So why might you want to break apart an evidence-based intervention at all? You can imagine an existing intervention that is very effective but very expensive to implement. As you or others try to move it out into the real world, you might hear that it can't be fully implemented in some key settings. Perhaps the full intervention is too costly to implement or takes more time or resources than are available. In these settings, stakeholders have a decision to make. They might decide not to adopt the program at all, or they might decide to drop or change some parts of the program in ways that fit their needs and resources. Unfortunately, in most cases, there is little to no evidence to guide the decision-making process about whether certain changes will work. What happens if stakeholders decide to remove a critical part of the program, making it ineffective or even harmful? As you will see by the end of this presentation, MOST provides a framework to obtain the data about what can be dropped or what can be changed while still resulting in an effective program. Following this process, you could potentially design gold, silver, and bronze versions of an intervention, with the silver and bronze versions of the intervention still having some effect, even if the effects aren't quite as strong as the gold standard. So what does MOST actually entail to accomplish these goals? To understand MOST, it helps to first consider the classical approach to intervention development and evaluation. The first step here involves using theory, existing evidence, or clinical knowledge to identify potential components to include in an intervention. These components could include content of the intervention that targets certain mechanisms, how the intervention should be delivered, etc. We'll talk about components more in a minute. The next step is to assemble all the intervention components into an intervention package that can be delivered to participants. Finally, the last step in the classical approach is to evaluate this entire treatment package, typically through an RCT comparing the intervention package to a control group or another intervention package. The key question that the classical approach attempts to answer is whether the intervention package has a significant effect on the outcome, which here could be suicide ideation, suicide attempts, or some other behavioral outcome. Notably, there are some things that an RCT alone cannot tell us. Suppose you obtain significant findings in an RCT. When you're evaluating an entire intervention package, you cannot determine which intervention components are making positive contributions to the overall effect, whether all the components are really needed, or how to make the intervention more effective, efficient, and scalable. For example, have we maximized the public health impact? Could we drop some of the components to make the intervention shorter or cheaper while still having a reasonable effect? Furthermore, an RCT that finds a non-significant effect doesn't tell us things such as whether any of the components are worth retaining, or whether one component had a negative effect that offset the positive effect of the others. In other words, was there an interaction among the components that is hiding evidence that one component actually had an effect? To address these limitations, MOST adds in an extra step: conducting one or more optimization experiments to determine which intervention components are working. This approach is inspired by an engineering framework, where engineers try to determine the optimal combination of components for a product. Specifically, by adding in an extra step to the process, MOST can compare individual components against predefined component-level criteria and determine how effective each component is. Using this information, researchers decide which components to retain and at what levels, and then they assemble the components into an optimized intervention package, and it is this optimized intervention package that is evaluated. A key goal of MOST is to evaluate the intervention components, in addition to later evaluating the full package. Importantly, one benefit of this approach is that we know which intervention components work, so the intervention is more transparent. These steps can be mapped onto the 3 phases of MOST: the preparation phase, which involves identifying the components; the optimization phase, which involves evaluating each component separately; and the evaluation phase, which involves determining whether the full optimized intervention works. Before we continue, let's pause and discuss intervention components in a little more detail, as they are central to MOST. Components are essentially an intervention's building blocks. Any part of an intervention that could be separated out for study is an intervention component. The first type of intervention component are features of the intervention content. Maybe your intervention has different lessons or modules. For example, lessons that target specific mechanisms in your conceptual model, or it could be that one component is using cognitive therapy, or a component is using skills training, a component where participants work with the therapist to set goals, or even a component where they engage in role-playing to deal with difficult situations. This type of component could also involve specific tools, such as a screening tool or a safety planning tool. Other content-related components might involve providing peer support, such as access to someone with lived experience, or alerts to notify clinicians when someone reports experiencing suicide ideation, or even medication. A second type of component involves how the intervention is delivered. For example, whether an intervention is delivered via telehealth or in person, or whether an intervention is delivered in an emergency department or an outpatient behavioral health setting or a primary care setting. Or another important feature might be the number or the length of sessions, or even whether follow-up occurs for 4 or 6 weeks. This type of component also can involve who delivers the program, such as whether the intervention is delivered by a social worker or a nurse. A third type of intervention component are features of an intervention that are designed to improve compliance. For example, perhaps the intervention includes text messages to remind people about scheduling follow-up appointments or reminds them to take their medication. In this case, not only could you consider whether to include reminders at all, but also trying to figure out what the best number of text message reminders to send would be. Another example might be whether it is worth it to include some type of gamification feature that will lead people to engage with the intervention more. Finally, the last type of component are focused on features to improve intervention fidelity, which in this case means that the intervention is delivered as it was intended to be. For example, perhaps the intervention includes some type of enhanced staff training, or there is some type of technical assistance provided as part of the intervention, or perhaps the intervention provides resources for staff, such as a chat feature that they can use when they aren't sure how to proceed. One final cautionary note. In order to be considered a component, the feature must be eligible to include in the intervention when it goes to scale. In other words, the feature is only included if the feature is only included for measurement or research purposes, it isn't an intervention component. For example, suppose you are planning a study and you plan to ask participants to record whether they had any suicidal ideation each day. If this type of tracking is going to be included as part of the final intervention, then it is a component. If, however, you are only asking them to record their suicidal ideation each day for measurement purposes, and they wouldn't be asked to do this outside of the research context, then recording suicide ideation each day is not an intervention component. Another example might be if you are sending text messages to participants to remind them to complete the intervention. If these reminders will be sent as part of the actual intervention once it's out of the research context, then it would be an intervention component. If, however, you are sending reminders only to remind people to complete the intervention so that you can collect data from them, then these are not intervention components. At this point, you may want to take a moment to pause this presentation for a brief activity. I suggest that you think about your intervention or tool that you are either planning to design or are in the process of redesigning, and attempt to identify all the different components that might be involved. Make sure the components are features that could be included in the final intervention and aren't just features for measurement purposes. I've put together a summary slide that I'll put up in a moment so that you can keep in mind the different types of components as you complete this activity. And here is that slide that I mentioned, summarizing the different types of components and examples in one place that you can keep up while you pause the video and brainstorm your intervention components. At this point, you should have some idea about how MOST is similar to and different from the classical approach to intervention development and evaluation. And hopefully you have a sense of what intervention components are, since they are so crucial to using MOST. I'm going to spend the next part of this presentation discussing the three different phases of MOST. As mentioned before, the first phase is the preparation phase. The goal of this phase is to lay the foundation for the optimization trials that you will later conduct. One of the key activities of the preparation phase of MOST is to create a conceptual model that shows you what each of your components targets and how that leads to the ultimate outcome or outcomes that you are trying to achieve. This activity usually occurs during or after the discover phase. You are likely mentally developing a conceptual model as you review the literature, the empirical evidence, and drawing on your clinical experience. But it is critical to make the conceptual model explicit during the preparation phase of MOST. It helps to look at some example conceptual models. Let's look at one for a hypothetical intervention. Perhaps you plan to create an electronic intervention tool that will have a few different features. The tool will send automatic text messages to remind people about their upcoming appointments. The tool also includes a coping skills module for the patient, an interactive safety planning tool, and a caregiver skill building tool. Each of these components targets specific outcomes. The reminder texts are trying to retain patients in care. The coping skills module is trying to improve patients' stress management skills and their coping skills. The safety plan is also trying to improve patients' coping skills, as well as help them create a plan to limit their access to lethal means. And the caregiver skill building component is trying to build caregiver self-efficacy for being able to recognize when an adolescent or young adult is in distress, and the caregiver self-efficacy for knowing when and where to seek help. Several of these targeted mechanisms are trying to reduce suicide ideation, which in turn should reduce suicide attempts. And several of the targeted mechanisms are not trying to reduce suicide ideation per se, but rather trying to reduce suicide attempts. So caregiver self-efficacy may not help reduce an adolescent's suicide ideation, but it may help the caregiver be able to identify when their adolescent is in distress and help them know how to get them the support they need at that moment to prevent a suicide attempt. Note that developing this conceptual model will be critical for conducting optimization trials, which focus on evaluating intervention components. You need to know what each component is trying to accomplish so that you know what criteria to use to determine if a component is effective. For example, if the caregiver skill building component can only be expected to address suicide attempts, you wouldn't want to use suicide ideation as a measure of success for that component. As another example, I will walk you through an actual conceptual model that our team had for an online substance use prevention program for college student athletes. Originally, the intervention had 5 modules or lessons, each targeting a specific substance like alcohol or tobacco. The alcohol lesson targeted harm prevention strategies, social norms about alcohol use, and expectancies about the outcomes of alcohol use, which all in turn are known to be connected to intentions to avoid alcohol use and prevent harm. These intentions in turn linked to substance use, which is then linked to negative consequences about alcohol use. The other remaining lessons each targeted 2 to 3 of these same proximal outcomes. However, what we learned during our first optimization trial is that interpreting the results during the optimization phase is much easier if each component targets a single proximal outcome. Notice here that all 5 lessons targeted social norms. And it turns out, if you convince students that they are overestimating how often their peers use alcohol, they will also realize they are likely overestimating how often their peers use marijuana, even if they don't receive the marijuana lesson. And it turns out this can make evaluation pretty tricky. As a result, we revised the conceptual model so that each lesson targeted one mediator. So we have one lesson targeting harm prevention strategies, one lesson targeting social norms, and one lesson targeting expectancies. This made the intervention components easier to evaluate, as well as more efficient for the students. 3 potential lessons instead of 5. Just a quick additional note about conceptual models. They really should focus on the process of change. How is the intervention expected to work? This differs from SEM models, which show all the relationships among variables. Those relationships are important and they can be tested post hoc. But for the purposes of most, we want to focus just on the process of change in the conceptual model. You may want to take a moment to pause this presentation again for another brief activity. I suggest that you think about your intervention or tool that you are designing or redesigning and attempt to sketch out a conceptual model. If it helps, you can use this template as a guide. You can either begin by identifying your intervention components, if you already have some idea what they are, and writing down the mediating variables that each component targets. How are these targeted mediating variables or proximal outcomes related to the more distal outcomes and later the ultimate outcomes you want to achieve? Alternatively, if you aren't sure of what your components are or will be, you can start with the ultimate outcome and work your way backwards. What does theory, past empirical studies, or your clinical experience tell you about what leads to this ultimate outcome? What might you have to target to address these factors that lead to the ultimate outcome? And then what components might you need to change these factors? Once you have sketched out the conceptual model, you can restart the presentation to learn more about the other activities in the preparation phase of MOST. Let's return to reviewing the activities of the preparation phase of MOST. In addition to developing a conceptual model, another key activity is to identify and create a set of candidate components. The conceptual model tells you what components you plan to include and why, and then you actually need to design and build them. A third key activity of the preparation phase is to conduct any pilot tests that are needed. For example, you may want to pilot test the components to determine if they are feasible or acceptable for your population. You may need to pilot test the measures or any other aspects of the study design before carrying out larger studies. And the fourth key activity is to identify your optimization objective that you will want to use for your optimization trials. Identifying key factors that can drive intervention uptake and implementation occurs during the discover phase, although you might not settle on the specific optimization objective until the end of the preparation phase. Identifying an optimization objective is new to many people, so let's take a few minutes to explore this activity in more detail. Optimization is driven by trying to balance 4 different things you want in an intervention. Collectively, these 4 desired features of an intervention are known as intervention E's. The first desired feature is effectiveness, how well the intervention works under real-world conditions. You may want your intervention to have as big an effect as possible. However, you must balance this goal of effectiveness against 3 other features. The first of these is affordability. To be used in the real world, the intervention needs to be affordable. You can imagine a situation where you design an extremely effective intervention at helping prevent suicide attempts. But if this intervention costs $10,000 per person to implement, it will be nearly impossible to get clinics to implement the intervention. You also want your program to be scalable. You want it to be implemented widely as it was intended to be implemented. With that in mind, you need to make sure that those implementing the program don't make ad hoc adjustments to the intervention in ways that haven't been tested. One factor that can affect scalability is how long the intervention takes to implement. If an intervention takes 2 hours, but an organization that adopts the intervention only has 30 minutes to implement it, they might drop certain components. That's okay if they know which components to drop while still having an impact, but it's problematic if they decide on their own what to do. The final feature is efficiency. You want the intervention to be delivered without wasting time, money, or other resources. An efficient intervention has no inactive components. Every part of the intervention does something. Note that there are always constraints at work. It's likely you could always come up with a better intervention with infinite resources of time and money, but that isn't practical. So let's use these 4 features to look at some possible optimization objectives. One possibility is that you want to create an intervention with no inactive or weak components. Here, you would be balancing effectiveness with efficiency. This is the criteria that teams I work with often use. Often, we are trying to develop online interventions where the components are brief lessons or modules, so time and cost are less important. In this case, we might want to only include lessons that have a meaningful effect in the final intervention. Another possibility is to determine what the maximum amount that your intervention can cost per person. Perhaps in order for clinics to adopt your intervention, they will only pay up to $50 per person. In that case, your optimization objective would be to assemble an intervention package that is as effective as it can be, but costs less than $50 per person. Finally, you may learn during the discover phase that in order for an intervention to be adopted and sustained in the real world, it needs to fit within a specific amount of time. For example, maybe staff only have 10 minutes to conduct the intervention. In that case, your optimization objective is to assemble an intervention that can be implemented in less than 10 minutes of staff time. What would this look like in practice? Suppose you identify 4 intervention components that are effective as part of your optimization trial. You determine that the total time to implement these 4 components is 30 minutes, which you know from the discover phase is not going to be practical. In this case, you can use your results to determine the most effective set of components that can be delivered in less than 10 minutes. Yes, this could mean that you will have to drop one or more effective components, but you are using data to do so, rather than people doing so on an ad hoc basis when the intervention goes to scale, in which case they could inadvertently decide to drop some of the most effective components. A few points to wrap up our discussion of selecting an optimization objective. First, make sure you explicitly identify the constraints before you get to the optimization phase. For example, during the discover phase, you will likely want to talk to stakeholders who will actually use your intervention to find out what they are willing and able to pay and how much time they will have available to implement the intervention. It's also important to note that you can use the data to select different components for different settings. For example, perhaps some settings have up to 2 hours available for implementing the intervention, and other settings have less than an hour. Or perhaps some clinics have the resources to spend only $50 per person to implement the program, and other clinics have $100 per person to implement it. You will have results from the optimization phase of most that will allow you to develop different versions of the intervention for different settings. In other words, you might be able to create a gold standard version of the intervention and cheaper or shorter, but still effective silver or bronze versions of the same intervention. Finally, identifying the optimization objective is important in the preparation phase because it helps you identify what data you will need to collect, for example, cost, time to complete, etc. By getting stakeholder input on what the relevant constraints are, you will be able to select an optimization objective that will help you create an intervention that is more likely to be adopted, implemented as intended, and sustained in the real world. Let's turn to the second phase of MOST, which is the optimization phase. In this phase, the goal is to build an optimized intervention. If you aren't familiar with MOST, you may feel a bit uncertain about this phase and what it entails. So hopefully the next part of my presentation can help answer some of your questions. Even if you are in the very early stages of your project, I hope that by hearing a bit more about this second phase, you'll have a better sense of where your project could be headed if you decide to use the MOST framework to design and optimize your intervention. The central activity of the optimization phase is to conduct one or more optimization trials. In these trials, you assess the intervention components rather than the entire intervention package. Specifically, you test how each component performs on average and how it performs when combined with other components. You will then use the data from your optimization trial or trials to identify a set of intervention components that combined meet your optimization objective. We'll talk about how to conduct the optimization trials in a moment. But first, it helps to see what the goals of these trials are. As a reminder, the focus is on the components, not the entire intervention package. The goals of the optimization trials are to identify any weak or ineffective components, determine the actual magnitude of each component's effects, and test whether there are interaction effects among components. In other words, does the inclusion of one component either improve or weaken the effect of another component? Hopefully at this point, you are starting to see the advantages of conducting the optimization phase of MOST. But if you are like me, you might be jumping immediately to, okay, but how can I actually optimize an intervention? For example, consider an intervention with 6 components. As stated before, the goal of the optimization phase is to determine how effective each component is. So realistically, how do we do this? The first thought that might come to mind is, does this mean we have to conduct 6 different RCTs? An RCT to test the first component versus a control group, another RCT to test the second component versus a control group, and so on? If so, that's going to take a huge number of participants to get this fully powered. Are you telling me that I would need to power 6 different studies? Or what about conducting a 7-arm RCT, where you compare each component to a control group? In other words, participants would be randomly assigned to receive one of the components or randomly assigned to get nothing. Sure, either of these designs would help us answer our question, but they would both be terribly inefficient because we would need a very large overall sample size to be sufficiently powered. Fortunately, there is a much more efficient approach that can be used, and it draws on a design that people have been using since the 1800s. This design is a factorial design. To make things easier, let's start with a two-component intervention. Here, component 1 can either be included or not. Component 2 can also either be included or not. When we cross these two components, we get 4 possible conditions. Participants randomly get assigned to one of these 4 cells. People who are in the first cell would receive both components. People in the second cell receive component 1, but not component 2, and so on. We can label each cell as a condition. This setup may look pretty familiar to you because it is often how we look at 2 different factors. However, when we have more than 2 components, it won't really be possible to use this format to display the different conditions. So let's display things a little differently, where we put each condition in a row and each component in a column. When we set things up this way, condition 1 is in the first row, and as you can see, people in this condition would receive both component 1 and component 2. Condition 2 is in the second row, and people in this condition would receive component 1, but not component 2, and so forth for the other 2 conditions. Now we can extend this to show more than 2 components. Here, we can see that if we have 3 components, we would have 8 conditions. When we want to test the effect of component 1, we will compare everyone who received component 1 to everyone who did not. Specifically, we will compare outcomes among those in conditions 1 through 4, who got component 1, to those in conditions 5 through 8, who did not get component 1. Notice, all participants will contribute to the analyses of this main effect. We aren't comparing one condition against everything else. For example, we don't compare condition 1 versus 8, which your gut might wrongly tell you should be the control group. Instead, we compare those who received component 1, outlined in blue, to those who did not, outlined in yellow. You can see when we are comparing these participants, half of those who received component 1 also received component 2, and half did not. And the same is true for those who did not receive component 1. So when we compare those who received component 1 to those who received component 2, we are averaging across the other components. When we want to test the effect of component 2, we will compare everyone who received component 2 to everyone who did not. So those in conditions 1 and 2, and those in 5 and 6 got component 2, whereas those in conditions 3 and 4, and those in conditions 7 and 8 did not. One way to think about this approach is that we are recycling research participants. Once we estimate the effect of component 1 based on a participant's data, we don't throw the data from that participant away. Instead, we will use the data they have contributed to estimate the effects of the other components. A very important advantage of the factorial design is that it is extremely efficient. Let's look at this a little more closely, as people often think they need to worry about power when they are considering a factorial design. Let's consider the design from the previous page. If we have a total of 304 participants spread equally across conditions, there would be 38 people per condition. That might start to feel a bit low. So are we sufficiently powered? Yes. Keep in mind that we aren't comparing people who received condition 1 to those who received condition 2 or condition 8 or some other condition. Instead, we are comparing everyone who received the component to everyone who did not receive that component. Here, that means for component 1, we compare the 152 people who received component 1 to the 152 people who did not. In other words, in a factorial experiment, the per condition n is not what determines power. Instead, what matters is the n per level of each factor, which here is for each level of a component. The same comparison works for the other components as well. Suppose we want to test the main effect of component 2. People who are in conditions 1 and 2, and people who are in conditions 5 and 6, received component 2. There are a total of 152 people who are in these 4 conditions. You can compare these 152 people to the people in conditions 3 and 4 and the people in conditions 7 and 8 who did not receive component 2. There are a total of 152 people who did not receive component 2. Again, we are using the full sample size to estimate the main effect of component 2. Keeping this in mind, it helps us to see that the number of components isn't what matters. Suppose we want to add a component, component 4, to our design. Doing so will double the number of conditions from 8 to 16, but we will still be able to have the same overall sample size. Specifically, if we think that the overall effect size is the same for component 4 as it was for the other components, then we can have the same power to detect this effect, even without changing the overall sample size. How? Even though there are half as many people per condition, there are still the same number of people in each level of the component. There are 152 people who received component 4 and 152 people who did not receive component 4. Therefore, the power is the same, even though we have not changed the overall sample size. There are 2 important take-home messages for you to keep in mind. First, all things being equal, you can add 1 or more components to a factorial experiment without increasing sample size. So it may be inefficient to conduct an optimization trial with only 2 or 3 components. If it is logistically possible to add more components, you may want to, as it helps to advance our understanding of what works and what doesn't. Second, factorial designs may have small numbers per condition, but they still have sufficient power to detect main effects. I don't want to spend much time discussing how to analyze the results from a factorial design, but I wanted to briefly mention a few things. First, although a factorial design can be a bit complex, the actual analyses are quite straightforward. You can generally use ANOVA or regression. The general form is just the outcome predicted by a pretest score, if you have one, plus a main effect for each component and the interactions among all of the components. Let's consider the hypothetical example I presented earlier for a moment. In that case, there were 4 components: a safety plan, a coping skills component for patients, a caregiver's component, and a text message component. Let's say we want to look at the effects of the components on suicide attempts at a post-test assessment. We set up the equation to predict whether or not someone had a suicide attempt at this post-test assessment, after controlling for whether or not they had a suicide attempt at pretest. If we decide that everyone needs to receive the safety plan component, we can't analyze the effects of that component. But we do include a main effect for each of the other 3 components, which simply indicates whether or not someone received that component. We then add the 2-way interactions among the components, as well as the 3-way interaction among all 3 components. Note that there is no condition variable in this equation. We aren't comparing one condition to another, but rather comparing those who received the component to those who did not. As a quick side note, for reasons I won't get into here, it is recommended that you use effect coding, where -1 indicates someone did not receive a component, and 1 indicates someone did receive the component. A few other notes. First, like any standard analysis, you will want to account for any nesting if you have people nested within some higher unit, such as clinics or primary care providers, and you may want to include control variables. Second, you should really consider what outcome variable to use in your analysis. Here, I use suicide attempts, which was the ultimate outcome in the hypothetical conceptual model. However, you may want to focus on the proximal outcomes of each component to evaluate that component. For example, perhaps you want to test whether the caregiver component actually improves caregiver self-efficacy. In that case, you would set up the model exactly as we have done here, but you would only focus your interpretation on the variables that are related to caregiver skills. So the main effect of the caregiver skills component and any interactions with the caregiver skills component. To wrap up this overview of factorial design, it helps to summarize a few key differences between an RCT and a factorial design. To start, the primary goal of an RCT is to estimate effects for a small number of experimental treatments. Often, we are comparing the effect of a new intervention to a control group or a usual practices condition. Or maybe we can compare two different treatments to each other and to a control group. By contrast, the goal of a factorial design is to estimate component main effects and interactions among components. Second, in an RCT, we estimate the effects by directly comparing individual experimental conditions, such as the intervention condition to the control condition. But in a factorial design, we estimate effects by combining experimental conditions. For example, we compare the average outcome among all participants in conditions that received a specific component to the average outcome among all of the participants in conditions which did not receive that component. Third, in an RCT, each participant usually only contributes to one effect estimate. By contrast, in the factorial design, we recycle participants, with each participant contributing to the estimate of multiple effects, specifically the effect of each component. Another question that often comes up about the optimization phase is about the decision-making process that happens at the end of this phase. Specifically, once you have completed your optimization trial, you need to decide what will actually be in the optimized intervention package. To do that, you first need to identify the important effects. You get to decide how to define important, although you should do this before you get to this stage. For example, perhaps you think that any component or component interaction that has a Cohen's-d effect size of 0.2 or greater is a clinically meaningful effect and is therefore important. Next, you need to use this information to divide the components into a screened-in group and a screened-out group. Figuring out if a component itself meets your criteria is fairly straightforward, but it can be a bit trickier to determine whether to keep components that are involved in an interaction. For example, the main effect of a component might not meet the criteria for being considered important by itself. But if that component amplifies the effect of another component, you should add it to the screened-in set. Alternatively, a component might have a negative effect on another component. In that case, you might want to consider removing it from the screened-in group. But be careful, if it just weakens an effect, but the two components together still have a net positive effect, you may still want to include it. Finally, you need to review the screened-in components to determine which subset best meets your optimization objective. This is pretty straightforward if the objective is just to build an efficient intervention with no weak components. In that case, all screened-in components go into the final optimized intervention. It gets a little harder if you have an optimization objective that is based on cost or time. Let's take a look at another hypothetical example. Suppose you have completed an optimization trial and identified 4 components that meet your criteria as important and are in the screened-in set. Perhaps your optimization objective is to assemble the most effective intervention that costs $150 or less per person. During your optimization trials, you carefully measure the cost of each component. For example, you know that component A costs $15 to implement and component B costs $25 to implement, and so on. Using this information, we can calculate the cost of each possible combination of these 4 components, shown here sorted from lowest cost to highest cost. Although we found that all 4 of these components were in the screened-in set, we can't afford to implement all combinations of these components. For example, the combination of components B and C costs $160, and implementing all 4 components costs $230. Now, we also want to implement the intervention that has the biggest effect for $150 or less. That means we also need to compute the estimated effect, or y hat, for each combination. I won't get into the details of how to calculate that value, but essentially it is computed using the estimates from your regression equation. Here, we see that among the combinations that we can afford, condition 3, which has components A, B, and D, has the biggest effect. Notice the advantage of using most to select the combination of components that should be in our final intervention, rather than have people select ad hoc which components they want to include. For example, someone might have decided to implement the program with just components A and C, thinking that the most expensive intervention that they could afford would be the best. Yet not only would this combination have cost more than the intervention that includes components A, B, and D, A and C costs $150 a person instead of $95 per person, the intervention with components A and C would have had a smaller overall effect, 3.64 rather than 3.85. We've spent considerable time walking through factorial designs, which are particularly useful tools for the optimization phase of most. However, it's important to note that many different types of designs are possible, and the selection of designs depends on your intervention and your research questions. For example, up to this point, we have focused on the development of a fixed intervention, where everyone gets all of the components, regardless of whether they need them or not. A factorial design works great for this type of intervention. However, you can also use an adaptive design, where people receive different components based on their responsiveness to the intervention. What might this look like? For example, suppose we are targeting people who have recently had a suicide attempt. Perhaps we start by having all of them complete a safety plan. Then they receive text messaging and peer support. After 5 days, we assess their suicide ideation and identify those who no longer have high levels of suicide ideation. We may decide that those with low levels of suicide ideation continue to receive text messaging and peer support, but nothing else. However, for those who have high levels of suicide ideation, they might need additional supports. Perhaps we continue to provide text messaging and peer support, and we also add access to cognitive behavioral therapy. In this example, you can see we have a lot of different components. First, the content itself, the safety plan, the text messaging, etc. Second, the tailoring variable, specifically whether or not their suicide ideation has improved. Third, the decision point, the time when the tailoring variable is assessed, so here 5 days. And finally, the decision rule itself. For example, that those who have lower suicide ideation only get text messaging and peer support going forward, whereas we will add cognitive behavioral therapy for those whose suicide ideation hasn't improved. Also note that if there is more than one decision point, the interval between the decision points can also be a component. There are multiple research questions in an adaptive design. First, does the initial intervention work better than a control? Second, does getting text messaging and peer support after 5 days work better than the full package for those who had lower suicide ideation at 5 days? And finally, does adding cognitive behavioral therapy work for those who didn't have lower suicide ideation after 5 days? You need a different design to answer these questions. Here, when you have a low intensity of adaptation, SMART is a good choice. If you want to test an adaptive intervention with a high intensity of adaptation, you will likely want to consider another design, such as the micro-randomized trial or a system identification experiment. Third and final phase of MOST is the evaluation phase. In this phase, the goal is to confirm the effectiveness of the optimized intervention. This is often achieved via an RCT comparing an optimized intervention to a control group or a usual practices condition. But it can also involve other designs, such as a hybrid implementation trial. It's important to note how we get to the evaluation phase. After the evaluation phase is complete, you must ask yourself, is this intervention sufficiently effective? In other words, is there strong enough evidence that the intervention will have the desired outcome? Even more specifically, is the intervention that meets my optimization objective, for example, the most effective intervention that can be implemented in under 10 minutes, likely to have the desired outcome? If the answer to this question is yes, then you can move on to the evaluation phase of MOST. However, if the answer to this question is no, then you need to actually return to the preparation phase. You might need to revisit your conceptual model. Are there additional components you might need to design and test? Are there changes you should make to the conceptual model itself? Or are there changes you need to make to the components to make them shorter or more potent? For example, maybe there are two components that together produce a strong effect, but take 20 minutes to complete. Are there any ways you can shorten these components while still maintaining their effectiveness? This return to the preparation phase shouldn't be viewed as a failure. Instead, you are working toward continued optimization and improvement of the intervention so that when it goes to scale, it can be effective and it can be implemented within the constraints of the real world. I also want to take a moment to share that you can actually build this continual optimization process right into your plan from the start. If you are newly developing an intervention, it's a lot to expect that your first version will be the best that it can be. Even if your components have statistically significant effects, it's very possible that you can improve them in some way. You might want to consider a process such as this one, in which you conduct an optimization trial to evaluate your first attempts at designing components, then revise any components that are ineffective or weak. Then you can conduct a second optimization trial to evaluate these revised components. And you can even conduct another set of revisions and a third optimization trial, and so on if desired. Finally, once you do begin the evaluation phase of MOST, there is one primary activity: to test the optimized intervention package. I won't cover this activity in more detail, as evaluation is covered in many other places, and there really isn't anything unique about the evaluation phase of MOST. Note, however, that you can consider combining the evaluation phase of MOST with the optimization phase. For example, you could consider a hybrid evaluation optimization trial in which you both test the optimized intervention and test one or more additional components. Our team has done this in several cases, such as when we wanted to evaluate an optimized intervention targeting alcohol use and sexual behaviors among college students, while at the same time testing a brand new component targeting sexual violence, which was requested by some of the colleges in our study after we had completed the original optimization phase of MOST. Before I wrap up, I want to spend a few minutes looking at some of the challenges that can come up when implementing MOST. If you're like me, all sorts of potential challenges might be popping into your mind that might make you concerned that you can't conduct the optimization phase in your study. And there are certainly situations where it isn't possible to implement all phases of MOST. However, I also want to encourage you to think about potential solutions to some common concerns that might occur. One common concern is when an intervention or tool has components that everyone needs to receive. For example, perhaps it's a requirement that the tool you are designing includes a safety plan. If so, you do not need to experimentally manipulate it. You can assign safety plan to all conditions. As you can see here, participants in every condition receive the safety plan component. One important thing to note that a constant component like this cannot be experimentally tested. Therefore, we don't know whether this component has any effect at all, and we don't know if there are any interactions between this component and other components. So in this example, perhaps the safety plan is critical for ensuring that the coping skills module works. If we hadn't implemented the safety plan, it's possible that the coping skills module wouldn't have worked or would have had a weaker effect. If you don't experimentally manipulate the safety plan component, you won't know about this interaction. Therefore, it's essential that a constant component is planned to be part of the final intervention. Another possibility is that you may want to test a component that has 3 levels. For example, Suppose you have a text messaging component because you expect that text messaging can increase engagement in the intervention and thus improve intervention outcomes. Perhaps you also want to do more than just test whether getting text messaging versus no text messaging works. Instead, you want to test no text messaging versus a low dose of text messaging, maybe 1 text message a week, versus a high dose of text messaging, maybe 3 text messages per week. We can still use a factorial design as shown here. You can see that now we have 12 conditions instead of 8, but everything else is similar. The problem is that now, when you make the comparisons among levels, such as none versus low, or none versus high, you are only using a subset of the participants. Therefore, all else being equal, you will need a higher sample size to achieve the same power. Therefore, the recommendation is that if you can get away with only 2 levels per component, that is better. For example, consider using none versus high in your first optimization trial. If you find an effect, you can later test whether low versus high has a similar effect. And if you don't find an effect at the high level, it may be unlikely that low would have worked. Another challenge could be if your intervention is designed to target an ultimate outcome that occurs much later, either later in development or later in time. Or you may need to quickly evaluate your intervention components. For example, I've used most to design interventions to prevent and reduce substance use. Ideally, we would evaluate each component based on its effects on substance use. However, we were constrained by how much time we had to carry out the study. We wanted to conduct all 3 phases of MOST within the time frame of a single grant, including multiple optimization trials, with time to revise the components in between those 2 trials. In our case, we decided to evaluate the components using the mediators in our conceptual model as our outcomes, because mediators generally change faster than the outcomes themselves. Specifically in our case, we evaluated the norms lesson by assessing social norms, the expectancies lesson by evaluating positive and negative expectancies about substance use, and the harm prevention lesson by evaluating intentions to prevent harm. Note, however, that there are 2 challenges to this approach. First, you should expect to see a larger impact on the mediator than on the outcome, given where it is in the conceptual model. Therefore, if you only see a small effect of a component on a mediator, there's a good chance you won't have much of an effect on the ultimate outcome. Note, however, that the final intervention will often be combining multiple components. So it is possible that when you combine components together, you will still get a reasonable effect on the ultimate outcome. Second, your conceptual model needs to be well supported. If not, intervention may change the targeted mediator, but not the ultimate outcome. If you are only measuring the effect of the intervention on the mediator, you won't know whether the mediator is actually causally linked to the ultimate outcome from the optimization trial alone. In our case, all 3 of these mediators had been strongly linked to the proximal and ultimate outcomes. Another concern people sometimes have is about the number of conditions they need to implement. For example, when we tested our first version of my playbook, the substance use intervention for college student athletes, we had an introductory component that everyone received and 5 experimental components, each targeting a different substance. We could have used a full factorial design, which would have meant we needed 32 conditions. Although this would have been possible for us, since our lessons were online and easy to manipulate, we wanted to balance Division I, Division II, and Division III NCAAs across conditions. With 32 conditions, we would have needed over 90 schools to have 1 school from each division per condition. Yet our power analyses indicated we only needed 50 to 60 schools. Therefore, we used a fractional factorial design, which cut the number of conditions in half. And here's what that design looked like. Notice it looks very similar to the full factorial design, and every component is balanced across every level of the other components. For example, among those who did not receive the alcohol component, half did not receive the tobacco component and half did. The same was true among those who did receive the alcohol component. half didn't receive the tobacco component and half did, and so on across all of the other components. Another question you might have is, what if I can't separate two components? In other words, what happens if one component needs to be included in order to implement another component? For example, I work on a project evaluating an enhanced mobile crisis program in North Carolina, which involves both 4 weeks of follow-up after the initial mobile crisis call and a family support person with lived experience who helps facilitate these follow-up visits. Let's take a look at just a two-factor design with follow-up and family support partner as the components. In practice, however, a family support partner is only included when follow-up occurs. They are not part of the initial mobile crisis response. As a result, condition 3 cannot be implemented. In this condition, no follow-up is supposed to occur, but there is a family support partner. A similar example might be if you have an intervention that involves both a peer mentor and text messaging. If the peer mentor is supposed to deliver the text messaging, then a condition in which text messaging is present but a peer mentor is not cannot be implemented. So how should you handle this situation? Well, one possibility is to combine the two inseparable components into a single component for experimental purposes. So here, perhaps you don't separate follow-up and the family support partner as two different components. Families either get both follow-up and access to a family support person, or neither. And then you test the other components, such as enhanced staff training. Alternatively, you could consider if there are changes you could make to the component that would make every condition possible. For example, instead of testing the presence or absence of follow-up, you could consider comparing 2 weeks versus 4 weeks of follow-up. In this case, follow-up always occurs, which makes it possible to test the effects of using a family support partner as part of the follow-up. Note, however, that if we don't find any differences between these two levels of follow-up, it could mean one of two things. One possibility is that 2 weeks of follow-up is sufficient and there isn't any added benefit of additional weeks of follow-up. This would be helpful to know because then we could make the intervention more efficient and affordable. Alternatively, no difference between 2 and 4 weeks could mean that follow-up itself isn't beneficial at all. There is no difference because follow-up doesn't have any effect on the outcome. Unfortunately, there is no way to tell which of these scenarios occurred. So, anytime you are selecting components that are related to dose, you need to really consider the actual values of each level of a component and how much dosage you think is needed for any effect to happen. In this case, maybe you could change it to 1 week of follow-up versus 4 weeks. Enough to have the family support partner involved, but not so much that you think much effect will happen. Also keep in mind that optimization is an iterative process. So you may not need to answer all questions in one study. You may want to first show that follow-up has an effect at all, and then in a future study, you can determine how much follow-up is needed to get a reasonable effect. To recap, in order to use a factorial design, the assumption is that you must be able to separately manipulate all of the components you want to evaluate. As we've already discussed, all combinations of the components must make sense. In addition, it's important that implementation is identical across conditions. That means that in the study of the Enhanced Mobile Crisis Program, you can't decide to include the family support partner as part of the initial mobile crisis visit in the condition where there is no follow-up, while only using the family support partner during follow-up in conditions that include the follow-up component. In this case, the implementation of family support partner would be different across conditions. Similarly, in a study with a peer mentor component and a text messaging component, you can't have a peer mentor send the text messages in conditions that have a peer mentor and use a chatbot to create and send messages in conditions that don't have a peer mentor. Here, sending text messages from a peer mentor in some conditions and sending text messages from a chatbot in other conditions would mean that the implementation of text messaging is different across conditions. Another thing to watch out for is if you have staff delivering the intervention components. They must deliver each component the same way, regardless of condition. So, if your components are delivered by trained counselors, the counselors cannot try to streamline the intervention by combining content from different sessions. They must deliver each session as is, regardless of whether a participant also receives other sessions. Of course, you don't want to waste participants' time by doing the same thing multiple times. But if you think there is overlap across sessions, a better solution would be to rethink the components or the content of the components, rather than cut material in some conditions and not others. Finally, another concern that people have is about how feasible it is for staff to deliver different conditions. In our experience, the key to successfully carrying out an optimization trial with many different conditions is to have very clear directions for each person implementing the intervention and to track what is actually implemented. For example, we have conducted a classroom-based study of an anti-extremism intervention in Bahrain delivered by DARE officers. We randomized classrooms to condition, so each class received different lessons each week. To help DARE officers keep everything straight, we created notebooks for each of them, which had each class's information at the top and a session-by-session guide to what they needed to deliver to that classroom, based on the condition the class was assigned to. We also asked officers to record when they taught each lesson, so we could identify if actual condition was the same as experimental condition they were assigned to. And we asked them to note any problems that occurred with intervention delivery. I would suggest anyone having people implement different conditions do something similar, so it is really clear for them what they need to do with each participant or group they encounter. Things are easier if your components are different features in an electronic tool, or if each person implementing the intervention is only carrying out a single condition. But as we have found, it's not impossible to carry out, even conducting the study in another continent with DARE officers who don't speak the same language as us. To wrap up, let's briefly review the differences between the classical approach to intervention development and MOST. The goal of the classical approach is to determine if an intervention package has statistically significant effects on the outcomes. By contrast, the goal of MOST is to eventually achieve statistically significant effects of an optimized intervention on the targeted outcomes, while also achieving intervention ease, balancing effectiveness with affordability, sustainability, and efficiency. In the classical approach, researchers move directly from tasks that we described here as part of the preparation phase, whether you label it the preparation phase or not, to the evaluation phase. By contrast, MOST adds an optimization phase, where researchers conduct one or more optimization trials specifically focused on obtaining data needed to achieve intervention ease. The classical approach often uses an RCT, whereas MOST uses many different designs, such as factorial or SMART designs during the optimization phase, as well as RCTs in the evaluation phase. The classical approach typically focuses on the entire intervention package, although you can try to determine the effects of individual intervention components within an evaluation of a full intervention package. Usually, this can only be done after the fact using post hoc non-experimental analyses. Whereas in MOST, the focus is on components. By focusing on components, we can also test interactions between components to determine if some components strengthen or weaken the effect of other components. Under the classical approach, weak components are tolerated. In fact, I've heard researchers who are skeptical of MOST argue that as long as their entire intervention package works, why should they care if some parts are weak or ineffective? However, very often our stakeholders, such as the clinicians who will be implementing the program and people who will be participating in the program, care very deeply about how much of their time or other resources are required to complete the intervention. They don't want to spend their time doing things that aren't working. Because of this, in MOST, the goal is often to remove weak or ineffective components so that the final intervention is more efficient. Finally, the classical approach often addresses scalability after an intervention is built, whereas MOST builds in a data-driven approach to consider issues of scalability right from the beginning. Thanks for joining me as part of this asynchronous seminar. If you have follow-up questions after going through the seminar, please feel free to follow up with me. I really look forward to discussing how you and your research team can incorporate MOST into your project. I'll leave you here with a few excellent resources as well. Linda Collins, the developer of MOST, has written an excellent book about MOST. Her Center for the Advancement and Dissemination of Intervention Optimization, or CADIO, is also an excellent resource, and I've provided their link here. Finally, if you're really interested in diving deeper into MOST, there is a free Coursera course about MOST developed and taught by Linda Collins and Kate Guastafaro. Kate is on the Expert Research Advisory Panel for the SCRC.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.